Okay, as we run through, let's see, we got the timing should work pretty well, shorten a little bit from last time. So what I wanted to start out with is hypoglycemia, the definition that our patients see when they go to ADA's website, American Diabetes Association website, because we're assuming that if they're seeking out education, that's where they find it. And as you can see, we state lower blood sugar and when your blood sugar levels are low enough that you need to take action. So it refers to their target. So again, an assumption the patient has an idea of what their target is. And this usually is when the blood sugar is less than 70. Now, it does make clear, however, talk to your diabetes team about your own blood sugar targets and what is too low for you. And I want to make this point because often we'll have emergency room visits when patients aren't clear, even though true, it seems, I'm sure everybody tells them again and again, this is what you need to watch out for. But I think the reality is, whether it's high blood sugars, there's theories on diabetes and cognition and long-term elevated blood glucose readings. But this is a reminder that we're going to repeat everything again and again often. So it's almost that, I know now we want to do paperless in a lot of areas. And sometimes when I bring it up to a clinic or an office of handouts, it's like, well, we're trying to go paperless. But unless you're an Instagrammer, LinkedIn, Facebooker, you're still with paper. Now, whether you hold it all the time, you're still with paper. So a lot of the little reminders that as providers, educators, coaches, we may feel, do we do it again and again? Yes, we need to do it again and again. Okay, often during ER visits, if we're lucky enough to catch the hypoglycemia during the ER visits, I think unfortunately a lot of times we get the fraction that occurs from a fall, and then on the way we're trying. You can move ahead. This right here is a perfect example of one of the things that we may sometimes feel like, are we inundating patients with information? Are we not? I recommend the offices sometimes of keeping this on the wall so that actually the nurse can just point to it as a reminder, pointing to it. If you don't give the patients paper each and every time, as pointing to it, it's a good reminder. Because again, look at these symptoms: shakiness, sweating, chills, clamminess, sweating, hot flashes, I get that on a regular, confusion, depending on how much coffee, hunger, nausea. I rarely have patients say, I felt hungry when I was low, but it is a reality. Rapid, fast heartbeat. A lot of patients, particularly in Southern Louisiana, there's problems with hypoglycemia and dehydration symptoms that we find coming to the ER. And there's a lot of things one is to consider with remembering about prevention and differentiating the symptoms of the two with assistance. And sleepiness and headaches, a lot of them are vague. So the patients really have to be aggressive and comfortable with checking their blood sugars and acting on it. Because again, the majority of these symptoms they'll come across, but again, education is the key for the patients as well as our staff. So again, one thing that's come up where I've noticed at the end of the slide, and I'll have, if patients lucky enough to have support system and a partner that'll share, he's been having nightmares. You wake up during the night. He started waking up through the night. We've been married 13 years. This is new. It's a big area where I'll just tell the significant other, just go ahead and prick his finger while he's sleeping if he's fine, or while she's sleeping, and check it. Then you know. Okay, so just want to throw that in as a reminder. This right here is, again, want to remind everyone the nuances of hypoglycemia. As you know, the patient that Dr. Lefray just brought up, everything's multifactorial, everybody's individual. I can only imagine how challenging that initial visit was, okay, just completing it. But when you bring up hypoglycemia, is what you said, that may be something you see in the future, the risk occur for several reasons and increase for several reasons. We do want our patients to be a goal. And if we can get a patient under 6%, perfect. But if they're on medications, we do want to realize there's a 4 times higher risk of hypoglycemia. It doesn't mean we can't get tight control of under 6.5, but just being aware and making sure that the patient can verbalize what they do with the elevated insulin. Right now, often we're really aggressive for several reasons. We want to get our patients better. We want to get our patients at goal. And also we have pressures from other areas now to do that maybe more aggressively or possibly quickly or quicker than we normally may desire. And again, patients get feedback from different areas. So I want to also caution, I really respect what you shared, Dr. Lovray, that there was so much going on. She was overwhelmed today. So we could say, okay, how soon do we get to 6.5? But we really have to take care of so much at a time. And of course, it's urgent. We want to get her down. But the more we can safely get her down and educate her and use these scenarios that she's going to walk through. As an example, it'll stick in a longer period of time. So of course, right now, she's an A1C of 20 on 19. So the most things patients say when they go to education classes, I've never been low. I don't know what that is. What, low? I'm not worried about that. And unfortunately, they're usually not. But as they improve, often we forget to flip back to that reminder. Now, insulin is a 5 times higher risk of hypoglycemia, as everyone here knows. Keeping in mind our hospitalization rates as well as ER visits. But if you do inpatient medicine, I want you to be aware that education with diabetes and patients with diabetes is important, but we don't want to forget education with our staff. We have hypoglycemia with patients in the hospital, and this is a critical time to keep that in mind, because if patients can't manage very well in the hospital with all of staff around them, just respect how challenging this can be. Okay, educated staff around them. So again, sulfonylureas, we know 2 times the risk. Perfect example of what you have today. Patient being over 75 years of age or cognitive impairment, because often things progress, 7 times higher risk. So again, what you want to keep in mind is when these patients have the risk, this is the game of diabetes. It is a constant challenge. So again, making sure they know when to be concerned. Also, is it when the staff member brings them in and the patient reports episodes of low blood glucose, these are the questions the staff member to assist, because again, it's a team, should bring up immediately. Did you have a meter? You don't? Oh, well, let's go, we can write for it. We may have a protocol or an order already. Any questions on this slide? This information came from a VA study that's written at the bottom. Okay, we can move further. I have this picture. American Diabetes Association has patient information. Also, Diabetes Care and Education Specialists, the association also has patient education. The biggest thing now is what you can attract the patient to look at. Not too much white space, not too little white space. It's actually a fine dance now with education, because we're fighting for attention. We're literally fighting for their attention. So this is one picture I have a handout or something that you can put on your computer or even print that I have the link to later that shows quick and easy things that can cause blood glucose readings to drop. Now, you know, I know, providers, coaches know insulin, diabetes medications, physical activity, alcohol, and nausea and vomiting. Our patients often forget, we say sick day training. I've done sick day training in classes, you name it, but sometimes patients don't click sick days. For some reason, they seem to see it as when they're going to the hospital. Patients often verbalize, well, I wasn't that sick. I vomited a few times. My baby girl had a virus, but they didn't realize that they needed to act. So just a reminder when we're speaking to them. Okay, the sick days, I think more and more we need to say nausea, vomiting, just not taking in your normal amount of carbohydrates. Sick days, patients tend to perceive it so differently. So keep it in mind. And if you'll move on to the next one. Okay, this is something that 15 and 15 rule. With years of teaching patients hypoglycemia for the longest time, everybody speaks of it differently. I'm almost on a crusade where if everybody can say 15, 15, the patients can remember it. It seems to have a nice rhythm to it, which matters with memory. So 15 and 15, this is a picture where Medline happened to have it. And so in the picture, you can see it brings up the picture of the clock. That's also memory, making you remember 15, 15, that core area, checking the glucose, eating 15 grams of carbohydrates. Now, if you look to the right, I want to remind also here, I was at a doctor's office for my appointment, actually, let's say 6 months into COVID. And it just so happens that a patient had a low blood sugar. So as I was walking up, people were gathered and the staff member ran out. One had a Diet Coke. Another person was looking for something in her purse. There was a lot of people around her. And the lady said, "Oh, I know what I did. I didn't eat." And she was very tiny, COPD, had a lot of challenges. But my point I'm trying to make is that often we have to be mindful as staff, people have to be mindful that when dealing with low blood glucose, things like bringing a regular Diet Coke, you think like, of course, the Diet Coke isn't going to work. But Diet Coke is almost like water nowadays, the way it's drank, called Coke Zero. So be aware, because in that case, as I come up, the patient had been sipping Coke. It's surprising how many people have Coke, hate to say it, including myself. But stress to the patient a regular soda. The one thing that I find in a lot of our training is when we tell patients 15 and 15 rule, before we go further, you teach a patient a lot by saying 15 grams of carbohydrates is 3 to 4 glucose tablets. I always tell patients, if you're buying glucose tablets again and again, we need to do something differently. So they often say, "Oh, I get it from the dollar store. They have a big bottle." And I'm like, well, let's talk, because if you keep on getting a big bottle, what referral we may need to put in place, or maybe we need to look further into it if possible. A half cup of fruit juice, just like Doc, you were saying earlier, you're told to pull away from her drinks. Well, often patients go fruit juice to make it, to fix a blood sugar. And I'm like, yeah, that's something that if you have diabetes, a patient with diabetes, we advise actually eating the real fruit instead of the half a cup of glucose. So often teaching about blood glucose prevention teaches them goes a long way. And now careful with peppermints. My belief is when I smell peppermints on a nice little old lady or a nice gentleman that comes in, I always stop and want to see the blood sugars. Unfortunately, they don't always have blood sugars, but that's when you want to key them in, because if the patient is eating peppermints on a regular basis and the A1C, no matter what it is actually, you want to stop and look into it, okay? And unfortunately, when we tell patients, just keep peppermints in your purse, very few people won't grab a peppermint when they're very bored or when their mouth just doesn't taste quite right. So throw out the peppermints, only blood glucose tablets, okay? 15 and 15, make sure the patient knows that once you take in the carbohydrate, the fast-acting carbohydrate, that you stop and wait 15 minutes. Unfortunately, we've had accidents. If you speak to EMS patients, EMS staff members, they will let you know that patients will say, "I had a low, but I drank something and then I started driving to work. It was low, but I ate and then I started driving to work." So make sure you check at 15 minutes to figure out, is it still trending downward? Sometimes that first rush of blood glucose, slight bump, not enough, can make them feel better. So stress this to decrease an ER visit or even fatality from car accidents. Now, once we want to remember is that once we know the number's normal, they need to eat a small snack or a carbohydrate and a protein. Right here, I notice our patients that have trouble with weight gain, when often we want to get them to check their blood sugars, because often they're fighting hypoglycemia and they don't even know it. They just know, I feel better when I throw the peppermint in. I feel better. I need to eat. I need to eat. So stress that. And of course, we want to make sure that they keep glucagon kit and their glucose tablets nearby. And after every low blood glucose event, we need to reflect. You can move forward. We need to really reflect, but also as staff members. So again, it's a team. So if your nurse, medical assistant puts the patient in the room, at that point, she should be asking about those symptoms, or at least when she looks at the blood glucose, she'll be preparing that thought process or having information out for you leading up to it. Now,
I apologize for interrupting. Is anybody else having a difficulty hearing Christine? Or is it just me? Okay, so I'll just have her repeat maybe this slide because I wasn't sure if it was me before or if it's her. Okay.
Yeah, it appears that she's frozen. So when she comes back on, we'll let her know to start this slide over.
Perfect. Hey, Christine. So you were frozen for a second. And so if you wouldn't mind just repeating this slide so we could hear everything. We couldn't hear you were frozen.
I'm so sorry. Okay.
That's okay. No worries.
With skipping meals, often we feel like patients should eat regular meals. And I agree. But when we find patients, I found that patients will say, well, I usually skip this meal. And often we want to say, well, don't skip your meals. But if the patient's eating 2 meals a day and they're 56 or they're 62, often when we say add in a meal, well, they don't, not purposely, but it's hard to remember because remember, they have to prepare that meal, they have to work with it. So keep in mind, if it's twice a day and we're doing mealtime insulin, well, consider whether or not twice a day, if they're checking their blood sugars, can fit into their routine. So that's something to just keep in mind across the board, because often we find patients may be on TID 3 times a day with meals, and patients will not feel like eating, but will just grab a cracker and take the insulin. And in a perfect world, we teach carbohydrate ratios to insulin intake, but it's hard. So just keep in mind your patient's habits, the types of meals. If patients do decide, for instance, yeah, I would like to pick up the habit of adding in that meal, just make sure that we come to an agreement on what that meal entails, whether it's protein, fat. People tend to eat the same thing on a regular basis. So the more you can discuss an option during the visit, when you have, as you have several visits, then it works out perfectly because the patient can end up having one meal that's consistent, one of the meals that's consistent. With fast food and portions, patients often do this because they're not preparing meals because they don't know how, or refrigeration can be an issue. So often I just go with portions. Okay, so keeping in mind the types of meals plays a role. So patients may forget and say, well, I can't eat fast food today. I'm not gonna eat, I'm gonna just go home. I'm not gonna eat with my sisters. Well, no, eat with your sisters, but you need to cut down on your portions. So we really focus on having them live the way they are and slowly work on perfecting habits. But if they do fast food every day, taking that out completely is a major launch reaction for major changes, emotional changes as well. Physical activity, don't forget, when patients are mopping their house, that's physical activity. So often we see a low, but we think about exercise as getting on a machine, going to a gym, walking in front. So keep in mind, mopping, sweeping, doing yard work, they need to realize how much of an activity that is, okay? And
Christine,
alcohol.
Do you mind if I interrupt you before we get to alcohol? There's a question. Somebody raised their hand, so I want to make sure we address this before it gets too late and they forget their question.
Sorry, go ahead. Is that Chris?
Yeah.
Okay.
I was just raising my hand about the freezing. Thank you. I don't have a question.
Okay, great.
You have anything, Dr. Lever?
Please go ahead. I don't mean to interrupt.
Okay, great. With alcohol, keep in mind, a lot of patients may drink old fashions, depending on where you live, what's the culture. Well, when we often say stop drinking, number one, a long-term habit includes a lot of emotional work. So keep that in mind. Also, if they do cut out mixed drinks, try and make sure we're aware of how much they actually drink. Long Island iced tea, different things, literally we'll see a big drop. And keep this in mind also Lent, if there's a large amount of Catholics in your area. I've never done a study, but we've had a large amount of complaints or issues with low blood sugar right after Mardi Gras, because a large amount of people completely drop and we're treating according to their previous habit. So keep those things in mind, whether they put a lot of sugars or they're getting 45 carbohydrates each drink or not, that plays a role. Because again, when you pull it away, did we pull away our medication along with it? Medication questions, that is one of the biggest challenges, because again, true, sulfonylureas insulin may have a higher risk, but we need to treat the patient. So again, it's more so keeping in mind, and the patient has to be educated. Also communicating with their healthcare provider. Patients need to have a way to link to the provider or the provider's team in order to be able to communicate. Often it may be, well, I had diarrhea, but I thought I was getting better. I had vomiting and I didn't know quite what to do. I was going to call maybe later when they weren't busy. So again, always a way to reach out to the provider. And what I'm stressing here more than anything is the critical thinking of options that we have to consider. Okay, you can flip to the next one. And one point also, we had a particular patient that, I'll give you an example. The cardiology unit didn't want her to bathe herself. She'd do a hand wash. Whenever she did, SATs would drop. I mean, it was such an ordeal for her to wash her own self. She'd stand up no matter what, because that's who she is. It was like she was running a marathon, okay, literally, but she was severely COPD. It took a lot of work. So keep in mind how everybody measures differently, okay? Now, here, often when clinics, and when I visit clinics, it'll be, well, I don't understand, my patients they're not picking it up. They're not educated, it's hard for them to retain. Well, make sure that your staff is able to educate. So if you're back at your clinic today, ask your staff, which things have high carbohydrates? Which things do you treat low blood glucose readings? Do they know 15 and 15 rule? So keep in mind diabetes vital signs. You can't prevent diabetes if you don't know what the numbers are. So again, your staff should see it as diabetes vital signs include glucose. Many patients often say, I stopped checking, nobody asked. I stopped checking, nobody asked. So again, your staff, first person to ask, you could even have your check-in person just remind them. If you have any notes or records for your doctor, please pull it out before you go in. Pull it out. Now, those notes may be a journal. The notes may be diabetes, blood glucose. It might be blood pressure. But your front desk can play a role in that as well, okay? Now, the home blood glucose readings, define your roles with your staff so that one person knows, or whoever puts your patients in, whoever gets them ready, knows that Dr. Loveray likes to have her blood glucose in the patient's hand. She likes the blood glucose on a note next to, depending on your EMR, you may be able to make notes. So make sure that that's clear. Then that way, when you do walk into a room where you're overwhelmed with so many issues, your staff members are there as a reminder. Because again, we have so many tools around us now. The continuous blood glucose readings are great, but I agree with Dr. Loveray, you have to first make sure the patient knows what they're looking for. Are they testing? Because I've had patients that we've had on the meters and say, well, how your blood sugars are going? They've been going great, but they've never looked at them since the last visit. And I'm like, oh my goodness, the reason we wrote for it is so that you can really critically think before and after meals, exercising and not. So keep that in mind, including when you're looking into diabetes devices, but also insulin pumps. If the patient isn't safe alone not checking blood glucose readings regularly, there's a lot of things to consider before we move further with technology, but also just reminding them their role when they have the new steps in technology. Okay. And one of the things I wanted to stress is there any barriers from everyone that's on the team, as well as anyone that's involved, where you've come across where it's harder to convince patients to check the blood sugars? What's your biggest complaint that anyone on board has to share with what's the patient barriers with bringing in blood glucose readings? Anyone with us today has any major pushbacks they receive from patients related to blood glucose readings? I'm frozen.
You are not. So today I had one that said just everything is painful. I just can't do this 5 times a day. Everything hurts. And I'm getting, hopefully for her, Freestyle Libre. But that's usual complaint for me is pain.
Gotcha. And I tell you what, we've done so well with insulin injections that patients feel the needle for the injection is so much better than pricking the finger. So definitely I agree. And I think when you come across it where patients have it, sometimes I've literally pricked their finger on their meter, okay? what we prick the finger with in the office is horrible. That, but on their meter, and especially I'll downgrade the device to where it's so low, it may be just a 1 or 2, and prick it. And sometimes they're surprised because they pricked their finger 2 years ago and it was tough. So needless to say, keeping good examples, but I'm glad that you just moved ahead and got the continuous glucose meter. And then we'll just remind the patient of actually looking at the blood glucose readings and often still writing it down like a journal, at least while we're ballparking trying to manage. Well, as always, I can go on forever. So here's some handouts, guys. These are 2 handouts that are excellent. They've actually been scored and reviewed where they're really good pictures where the patients can see it quickly, as well as your staff, as reminders to make sure your staff is familiar. We probably can't, I'm not sure, Jill, if it's a live link or not, but definitely I'd encourage you to access it. If you can click it now, you can see it. If not, I recommend you go to it because again, the site is excellent with a lot of resources. And the next slide is just a reminder. Again, I know everybody's on here, we all know about educators, but want to make sure you have another resource that we'll have on our website one more time where we remind you to reach out for assistance. Educators, coaches are out there.